One of the most challenging parts of behavioral restraint is making the initial decision to restrain someone. We worry about violating their civil rights or somehow otherwise doing something that's not legally justifiable. But we also worry about our own safety, and not to mention the patient's as well. So while we definitely need to be cognizant of the fact that our patients, they have civil rights too, we also don't want to be paralyzed by a fear of litigation in situations where there is justifiable reason to use restraints. And in general, this isn't true everywhere, but in general, the court tends to be very favorable toward EMS. If a jury looks at your case and says, you know what, if I had been in their shoes, I probably would have felt like this person needed to be restrained too, they're going to tend to err that direction. So don't be paralyzed by fear of using restraints when you need to use them. But I get that it's difficult because not every patient is a black and white decision of do we restrain or do we not. You have obvious situations where the person is a threat to themselves or someone else. Those are pretty clear cut. But what about all those patients that fall in between, those gray areas? Is there any way to know in advance which patients are going to turn violent en route to the hospital, even though they were initially cooperative on the scene? As I sit here and think about the over 200 reports that I've read and incidents of assaults on EMTs and paramedics where the patient turned into an assailant later on, it's almost funny how many times I've seen those words, initially cooperative, used to describe the patient's state of being at the start of the call. On scene, they were completely cooperative, but when we got en route to the hospital, it's like a light switch got flipped and they Jekyll and Hyde on us. But it's not always quite that sudden and unexpected if we look for the signs. I want to take a moment here just to change gears a little bit before we move on. This is the interactive portion, and we're going to do this pretty quick, so try to keep up. Start out by thinking of a number between 1 and 10. Okay, now take that number and multiply it by 2. Now add 8. Divide that by 2. Now take that calculated number that you've come up with and subtract your original number, the one that you picked between 1 and 10 at the very start here. Have you got your final number? You'll see a table with some numbers and some letters. Now looking at this table, think of a country that starts with the letter that corresponds to your number. Take a second and think of a country that starts with that letter. Take the second letter of that country's name and think of an animal that starts with that letter. And also think of the color of that animal. I'm going to read your mind. I believe that you were thinking of a gray elephant in Denmark. It's not magic, obviously, it's just mathematics and probabilities. There are only 4 countries in the world that start with the letter D. You've got Denmark, the Dominican Republic, you've got Dominica, and then there's one that I can't pronounce, and I'm not going to embarrass myself by trying. Statistically, in our hemisphere, people are just more likely to choose Denmark. We're betting on the odds here. It's not a certain prediction, it's just more likely than not, it's going to be a correct guess. Now, what was the point of all of this? While we can't use a crystal ball to figure out who is going to turn violent later on. Is there something we can use, like some warning signs, some common themes that pop up in situations where someone is more likely to assault the paramedic or EMT in back of the truck? And yes, there are. I've looked at those 200 reports for common elements, scanned through them, trying to find things that pop up pretty frequently. And I'm going to share those with you in a moment, but I've been talking about these reports. Now I want you to actually see one of them. It's a routine psych transfer, and the trip lasts about 3 hours. When the crew arrives at the hospital to pick up the patient, the nurse tells them that the patient had trouble with women and sexually assaulted and killed a cat. The crew decides not to use restraints, and they begin transport. About an hour and a half into the trip, the patient becomes what the attending paramedic describes as psychotic. Eventually, the patient starts to unbuckle the seatbelts on the stretcher and try to get up. The paramedic tries to stop him, and for his trouble, the patient punches the paramedic in the face and then bites down on his finger. After trying unsuccessfully to get his hand free from the patient's mouth, the paramedic felt he had no choice but to use his free hand and punch the patient in the face.
Oh, that's gonna leave a mark.
Finally, law enforcement arrives and the patient is given Versed, 4-point restraints, and a spit hood. Amazingly, the remainder of transport was uneventful.
I wonder why.
Now, if this had been your patient, would you have put them in restraints prior to leaving the hospital based on what the nurse told you about the patient? I mean, his behavior was definitely bizarre. Would you agree? Their behavior falls under the category of unpredictable, and unpredictability increases the danger. I looked at those over 200 reports through the event system, and I found that in cases where a paramedic or EMT was assaulted en route to the hospital, 90% of the time, there had been warning signs clearly evident prior to leaving the scene. What were these key factors? By far the biggest one was alcohol intoxication. Big surprise, right? Now, this is not to say that every drunk patient should be put in restraints necessarily, and it doesn't mean that every drunk patient is going to try and attack us. What it does mean is that of the people who attack us, there's a good likelihood that they are also intoxicated. It decreases inhibitions and it decreases their level of rational thinking. You can't reason with someone who's drunk or high. Behind that, we have psychosis or bizarre behavior. Psychosis, what I mean, is hallucinations or delusions. They're seeing things or hearing things that aren't there, or they believe themselves to be Julius Caesar, or Jesus Christ, or whoever. In those cases, there is an unpredictability factor, just like there is with bizarre behavior. I set that apart because there may not be evidence of hallucinations and such, but their behavior is completely abnormal. For example, I read one report where the patient had been walking around the inside of a restaurant, putting their face through every window that they came up to. That's a little abnormal.
Well, duh.
Yeah, a little bizarre. The next one was police assist calls, followed by psych patients. It's not just having a psychiatric diagnosis, major depression or an anxiety disorder or post-traumatic stress. Those are psychiatric labels, but it doesn't necessarily make them dangerous to us. But if a person has poorly controlled schizophrenia or a bipolar disorder that is poorly controlled and the person's not taking their medications, or someone with a borderline personality disorder, which often is characterized by very volatile mood swings, in those cases you've got increased unpredictability. That is the key feature. Involuntary patients, I'm talking about the ones who are really angry. They don't want to go. Emotions can run high. That increases volatility and, by extension, unpredictability. Suicidal patients also carry a higher risk. Now, this doesn't mean every suicidal patient's going to be dangerous. In fact, it's probably a very small minority, but their thinking can be clouded. Rationality has gone out the window. And in those cases, just be aware that there is an increased risk, especially if you see any of the other factors on this list. The same thing goes for altered mental status in general. You'd be surprised at the number of assault reports I've read where someone who is just coming out of a seizure, who is normally the most calm and polite church-going person, has all of a sudden turned into Mr. Hyde when they are postictal. They're not themselves, they're not thinking clearly, and therefore they are not going to behave as a normal, rational thinking person would behave. Threatening body language or tone of voice, that should definitely alarm you. Patients who are known to be violent offenders or who have a history of becoming violent under similar circumstances. So take that postictal patient for a moment. Let's say that when you arrive on the scene, the wife tells you, the last time he was like this, last time this happened, he beat up our neighbor, and that's not like him. Could you use that as justification to restrain that individual today, even though so far nothing's happened?
No. Well, yes.
Absolutely, because the best predictor of future behavior is relevant past behavior. Just document what was said and who said it. Be very clear and very detailed in your narrative. If the patient was aggressive toward anybody prior to your arrival, so if they fought with police, that's a pretty good sign that they may be willing to tussle around with you. If they were at any point in time in custody or handcuffed by law enforcement, if the police felt they needed to be restrained, you should too. If you have a transfer patient from a hospital who was at any point in time restrained, sedated, or secluded in the emergency department, even if a nurse tells you, oh, but he's been really compliant and cooperative for us the past few hours, and he's not given me any trouble, and he had Haldol, several hours ago. You shouldn't need to worry about him. I would still put that person in restraints because in a relatively recent span of time, that person was aggressive for someone else in a place where there were multiple personnel available should something go wrong. There's only one paramedic or EMT in the back of the ambulance typically. That's a whole other setting. It's not controlled. There's no security team to call for. You're in the back of the truck alone with that person. So don't just take the nurse's word for it. The patient's history has already determined the greater risk. Put them in restraints before you even leave the ER. A lot of the time, actually about a third of the time, the crews only choose to put them in restraints because they were assaulted, and that's way too late in the game. Prevention is always better than crisis management. Now, I want to caution you that this list is not intended to be used as a prediction tool. We can't, for example, take this list and say, if any one of these items is true about my patient, we definitely need to put him in restraints, because if we don't, he will definitely try to kill us. You can't use it that way. So we can't look at it and say, okay, so every postictal patient is going to try and harm me, so we need to put every postictal patient and every hypoglycemic patient in restraints. That's not what I'm getting at here. It's not that every drunk will try to kill us. It's not even that every person who was handcuffed at some point in time would try to kill us. What I'm saying is that of the persons who do assault EMTs and paramedics, more often than not, one of the things on this list or more was true about that patient. So when you see one, you need to have a higher level of alertness. Consider restraints a little bit more than you might otherwise. You see multiple things on this list, chances are you should definitely put them in restraints. But what if you have someone that doesn't quite fall into any of those categories clearly? Or maybe they only have one or two things on that list that really don't seem all that extreme, but your gut is still telling you, man, I can't think of a justifiable reason to put them in restraint, something that would be legally defensible, but I just can't help feeling really creeped out.
I got a bad feeling about this.
Can't put my finger on it, but I'm not comfortable with this. Well, perhaps you have something like this on board your ambulance. Seatbelt locks. Great device. I wish they had been on every ambulance years ago. However, as great as they are, they only provide a minimal level of security. Can they be beaten? Yes. Unfortunately, I can't provide you with a yes or no answer to every what-if situation. There are just too many hypothetical scenarios to go over. So you're going to have to use your own best clinical judgment. You're a professional clinician, so you've got the skills, you have the ability. The next universal principle of restraint is know your role. Clearly distinguishing the role of EMS in a restraint situation from that of law enforcement. The two often get blurred, and that is to our detriment. So we want to make sure that there is clear distinction between the two. Who is most qualified to take down a violent person? I'll give you a hint. It's not EMS. Here's the thing about law enforcement. They have the tools, okay? They don't fight fair. They've got things like OC spray and tasers, batons, and, police dogs, and then obviously guns, okay? We don't have any of that stuff. So they've got an advantage that we don't have. And the other big advantage is training. A little bit of a difference there. We've already established that EMS training in the use of restraints and the legal considerations and so on and so forth is very lacking. But as bad as that lack of training may be, there is at least one other thing that I can think of that is 10 times worse. And that's when EMTs and paramedics, firefighters try to compensate for that lack of training and preparation by imitating something that they saw a law enforcement officer do on a scene, or maybe something they saw in an MMA fight or an WWE. But pretending to be Dirty Harry or Randy Couture, Ronda Rousey, or Stone Cold Steve Austin, that's a very dangerous game to play. And besides that, arm bars, leg locks, and chokeholds don't necessarily fall under standard of care. Now, I can already hear some naysayers out there, especially really macho guys who think that EMS providers should be able to completely handle themselves and take down these people. I have 3 thoughts for you if you fall into that category. Number 1, that whole belief is a complete disregard for the idea of scene safety. Everything that we were taught about scene safety, we throw out the window if we believe that way. Secondly, you will eventually meet someone who is bigger, badder, better, and stronger than you. Sorry, that's the truth. And then lastly, if you really want to be able to manhandle people, okay, I will submit to that. If you and your agency, being responsible, are willing to commit to the same amount and level of training that law enforcement receives in the use of restraint, use of force, constitutional law, and so on and so forth. Short of that, you have no business doing it. In my mind, the sequence of events in a restraint scenario that keeps in mind the differentiation between law enforcement and EMS would be this. If necessary, law enforcement are the ones to subdue the person, and then advanced life support paramedics come in and administer some sort of chemical restraint agent, and then all of the persons on scene participate in applying physical restraints once the patient has been sedated enough to safely move them to the stretcher. And then lastly, EMS does their thing, which is monitor, treat, and transport.